I mentioned at the last meeting that we anticipate having to create a new strategic plan, and I think that's going to be something that will be a COC, which is Lauren's position, and an SMP, which is my position, combination thing. So once Lauren and I get a final deadline of when that's going to be due, she and I will, and with Hillary, will wrap our heads around how we want to approach this, and then we likely will be reaching out to all of you as partners to have some discussions, conversations, and have you help us guide and plan this strategic plan. So just keep that again in the back of your mind. We are in the kind of wrapping up stages of this parent video series project that we're working on with Roll Films, and we're really excited to get that going. So once that's, I'm hoping by the time we have our next meeting, we'll be able to have disseminated that and put that out to our community. So excited about that. And like I've talked about before, really just in the planning stages of doing a very targeted implementation of this Talk They Hear You campaign over this upcoming fiscal year. And I think that's really it for me.
Awesome, thank you. Hillary, do you have any updates to share?
Sure. Similar to Andrea, it's been pretty quiet. Just more of a, I guess, a pre-planning for everyone on the call. So our next meeting will be at the end of September. September 28th, I think, is the date. As you know, we are currently in year 8 of our DFC grant. It is a 10-year grant, so we will be heading into year 9 at the end of September. And we would like to use our September meeting to really dive into a discussion around sustainability. What does sustainability look like for All Together post our DFC grant? So we have someone from our evaluating team, Kelly Keck from Epiphany Community Services, coming to help us facilitate a conversation around sustainability. So just want to put that on everybody's radar. We will be sending out sort of some high-level bullets of things that we're going to be talking about at the meeting, and would love to have all of our partners in attendance to help us figure out what you guys think are the things, the activities that All Together does, the things that we do well that would be worth sustaining. We also just recently got our results back from our coalition member survey that we sent out in May. Our May meeting was really the start of that survey. So we just got the results back. Instead of, normally we would go through the results at a meeting, but because we really want to devote the September meeting to a sustainability conversation, we're going to be sending out the report from our coalition capacity survey in an email. And we'll include in the body of the email probably our top 3 to 5 highlights that are worth pulling out from the report. But if partners are interested in reading the entire report, we will attach it to an email. So just be on the lookout for the report, and then closer to our September meeting, some high-level topics to think about to bring your responses to for our discussion around sustainability. That's it.
Awesome, thank you, Hillary. I'm going to have Havela go next. And Havela, I don't know that you've attended one of these meetings yet before, so maybe you could just reintroduce yourself, and then I think you're going to tell us a little bit about the project you're working on.
Yeah. So I just started like a month ago, and I'm working with Lauren on a short-term 3-month project on overdose prevention. So right now I am in the data collection stage. So I'm collecting quantitative data from the EMS departments within the Upper Valley and the Greater Sullivan Public Health Networks, as well as data from like the DMI dashboards on overdoses within the region. And then I'm also creating a list of the resources within the regions to show where the gaps are between the resources and then the high risk populations. So that's what I'm working on with Lauren, and yeah.
Awesome, thank you. And as for me, I don't really have a lot of updates either. I might have mentioned in the past that I was working on an event with the Newberry Library, which is in the Sullivan County region. We hosted that last week, and it was all around opioids mainly, but it went really, really well. So I'm hoping that we can replicate that in other communities, partner with other libraries. And I would really love to start holding like regular Narcan trainings in the future, like having them, planned monthly or every other month or something like that. So that's just something that I have in mind, and hope that we can bring one to the Upper Valley area very soon. And then I also just wanted to mention that we have a supply of fentanyl test strips that we got from the state. So if you hear of any organization or if you're looking for any at all, let me know. And I can get some to you. I can connect with any organization that is looking to get some of those, free of cost. We got a whole bunch from the state. So
Looks like we lost Lauren for a second. So I will take over while we're waiting for Lauren to rejoin. So yes, email Lauren if you know of any organizations who might be interested in some fentanyl test strips. I'm not sure how many she has, but I know that she's gotten a bunch. And we have had some partners reach out already. So let us know. And I'm not sure if this was this is how much we get and there's no more, or if we'll be able to replenish once we run out. So if you have further questions about that, send Lauren an email. She'll be happy to respond to you. Let's see. So we are a little bit early in our agenda, but since Tony is here, I would love to invite Tony to talk to us about the project with the Upper Valley Public Health Council and sort of the work that you're doing. So I will turn the floor over to you, Tony.
Cool. Perfect. Yeah, so I introduced myself a little bit earlier, but I was hired under a CDC grant to be an equity facilitator to help kind of combat some of the health disparities that have existed and also have escalated since the introduction of COVID-19. And my goal pretty much is to get funding. So I have $150,000 in our district, and that covers, the Upper Valley, so that it's through the state of Vermont, but it covers the Upper Valley region, including New Hampshire, due to the fact that many Vermont residents get services in New Hampshire. So there's a little overlap there. The funding is process is in the works right now. We have a steering committee. We meet about once or twice a month. And it's an opportunity for community members that have gone through working together to really prioritize what are the key issues in the area regarding health disparities for marginalized communities. And how can we get the funding to the marginalized organizations that support marginalized communities and help combat those health disparities that are existing. The process is interesting. There are definitely similarities throughout the districts, but there's a uniqueness here in the Upper Valley, and I think that everybody here can kind of understand that too. The fact that we are so close to the New Hampshire border and Vermont border that there is a lot of overlap in our communities that doesn't exist in a lot of parts of Vermont state. But one of the things that we're working on is, which is a requirement of the CDC grant, is to give funds to organizations, but it's also prior to that is doing assessments of the community, of our steering committees, of the people doing the work, as well internally in the Public Health Council and the steering committee, as well as in the community, as far as providers and how community members are perceiving their care and how providers are perceiving the care that they're providing. And it's an opportunity for us to kind of collect the data and even look at aspects of the narrative data and qualitative data that is there to really understand what is happening in the community. To get the qualitative data, I'm kind of running in a grassroots manner where I'm on the ground I'm meeting with community members face to face. I'm getting a lot of the qualitative data through conversation. And that has been very enlightening because you can see really the missing pieces to the data, the quantitative data, because of the qualitative connections that we're making and information that we're getting. A lot of people, talking to people about their experiences and what are the challenges that they faced, especially during the pandemic. Was it transportation? Was it mental wellness? Was it access to mental wellness care that was inclusive, that felt culturally competent and representative, or is that a lacking? If you say, for example, there is heart issues that exist in a certain demographic or population, and they're struggling to get the resources for that. The funding, the hope and the goal of the funding that the CDC grant has given us is to distribute that funding to organizations, whether they're 501c3s or they're just community organizations, and giving them the funding to create or sustain the work and capacity build in ways that really helps tackle these health disparities. We only have 1 year under this grant to get these funds distributed. So it's a very short-term project. I would like it to be a lot longer, but because I feel like it could make a big impact if it were lasting longer. But I can see the benefit of the impact this year if we help give funding to community organizations and community members who are building organizations or building collaborative groups in order to tackle some of the key issues that has contributed to the health disparities they're experiencing. That could be, for example, someone could say, hey, I'm struggling with getting transportation to, say, dialysis. I'm struggling to get transportation to dialysis. Okay, so if we see that, all right, there's not equitable transportation for people who are lower income, especially the people who are of color or LGBTQIA+. How can we fund organizations that will go and tackle that transportation piece, and that so that they can have better, care to dialysis, continuous care, less disruptions. And the data out there that it exists currently, the quantitative data is one part of the story, but it's really the qualitative data that backs up the quantitative data. And looking at that and saying, okay, I'm meeting with community members, I'm going to organizations, meetings, public events, connecting with community members about the work that I'm doing, creating community engagement, and trying to understand the experiences that others are facing, and how can we contribute to creating connections between providers and support in the communities, and how can we get the funding in the right places to build that capacity of support. And that's really why I'm brought in, and I hope that wasn't too hard to follow. I know I talked to a lot of other people in my role in the other districts, and we meet once a week, and it is such a learning opportunity for all of us. And to know that we are the teacher, we are the student, simultaneously, consistently throughout our work, and knowing that we are constantly, facing challenges in ways, but it's also, we are connecting resources with each other too, like Windsor County and Springfield specifically going, oh, I didn't know this resource existed down there, or they're trying to work on this similar health disparity, or this group is trying to do similar work to this other group in the Upper Valley. How can we make these bridges and connections? But I think that this is a great opportunity for organizations in the area who really can make an impact with funding to help the health disparities of marginalized communities in the area. there's a lot of information out there about health disparities and equitable care. Yeah, and I just, and if anybody ever has any questions or goes, hey, I'm having this issue, hey, can you provide this resource, or do you know a resource? I may have come across it, so I can pass that information off to you as well. If you're struggling to develop knowledge about a certain situation or want to develop your knowledge just because, there's a lot of great resources out there, specifically pertaining around healthcare, employee workforce, education, that is helpful. My other, I work for Public Health Council part-time. My other job is as the DEI coordinator at Thetford Academy. So I have a whole different realm here. But you can see that there's a lot of overlap in ways where you can hear from community members. Oh, there's one community member. She's Latina. I've known her my entire life. I'm an alumni at the school, but she, her family and my family were the only Latino families in town when I was here as a student, and she's struggling because she's the sole provider for the house. She has a sense of responsibility. She's really trying to find resources to get her father to dialysis, and there's a struggle. There's a struggle where she's the only one. She's a chef, so she's constantly cooking, and she has to be in person. She can't do remote work. It doesn't exist for her, and she has to go through the transportation piece, getting her mom to work, helping translate for her parents, helping all this aspects of that are additional struggles that her family experiences, just because either the resources are not there, or she's struggling to make the connections of resources that can help her family's needs, because people have different needs. So it's kind of, that's just an example of how this funding can go and help fund and give money to a transportation company that can then help work on the specific issue of how do we do this in a way that's culturally competent, and how do we understand the unique roles and family dynamics of other types of families. That's the hope in the goal, is to put this work into action and really build capacity in the community for these unique experiences that every person may or may not experience, based on based on the inequities that exist in services provided. And I think a lot of people are recognizing, even in their own work, is saying, oh, this, we didn't think of this way, or this piece isn't being covered. This quality of service can be revamped and upped, if we look at how can we fund initiatives that can really support health disparities in marginalized communities. Yeah, and in looking at the stats and looking at the situation is, I developing my data to develop a problem statement. When it was data-driven problem statement, was okay, well, ton of data, but then not enough of the data that I want, not enough of this, and kind of piecing things together, and noticing that with COVID, there was so much data and so much funding behind data during COVID that I feel like there's a lot of data that was missed, particularly about marginalized communities. You can look at substance use rates went up, or suicide rates went up, but what about, who were these individuals, and was that different based on someone who is a BIPOC person, or is that different for someone who's LGBTQIA plus? Does it differ based on their age? Are they an aging adult, or are they an aging BIPOC member? And is that affecting them more deeply? So there's data that could have been there that's not there. And it's kind of closing the gaps of that and saying, okay, now I'm on the ground, talking to people, trying to collect that data that was missed, and using that in the right way. So that's kind of the gist of the work I'm doing with the Public Health Council. And I'm not sure if there's time or room for questions or anything. I'm not, if there is, okay, there is. Okay, so if anybody has any questions or wants more clarity, I am a firm believer of there are no real stupid questions. And if there are, I probably may have said them at one point or time in my life. So never feel ashamed to ask a question.
I have one, Tony.
Yeah, sure.
So I know, this, you had mentioned that the role is funded through the state of Vermont, but because of our uniqueness of living in the Upper Valley, you have the opportunity for funding to go to organizations on the New Hampshire side. Just curious, has your, when you have dove into the data, dove, whatever,
Okay.
as you've been collecting your data, has it just been focused on the Vermont side, or has it included New Hampshire as well? And then what sort of like age groups are you including in collecting this data? And then I'll explain kind of why I'm asking this in a second, but just curious, is it just Vermont that you're looking at for your data collection, or does it include parts of New Hampshire as well?
It's here's I'll give an explanation of this, and I'm not sure it would be the answer that you're hoping for either. But hopefully
Okay.
this can help. So the data that we're looking at is primarily for Vermont because it is Vermont CDC grant. But it can go into organizations. The funding can go to organizations on the New Hampshire side that provide services that include Vermont residents. If the services provided exclude Vermont residents and state that, then they would not be eligible for the funding. But if they are saying that they're available because they have funding for Vermont residents, then yes. And the data I was looking at was primarily Vermont residents on the Upper Valley side. But I did look at data in the New Hampshire side too, just as a curiosity and comparison, to see if there was similarity. And I think that, Vermont looks at it as a whole. They don't look primarily as like sections, and some of their data, they've done it by county or by certain regions. But the data that I've been looking at a lot is Vermont just as a whole. And if you look at the different counties and stuff and the movement of counties, too, it's interesting to see. But there's a lot of similarities between counties in Vermont. I think the only county that really does stand out substantially different is probably Chittenden County near Burlington. Definitely has a significant difference just because of the amount of diversity that exists there comparative to the rest of the state. And it being more populated. And then, but mostly Vermont residents and age groups. It's kind of looked at adolescents and adults could be 18 plus. It's not primarily focusing on aging communities, but I have looked at data for aging communities because we do have a growing aging community, and that's nationwide. In the next by 2040, we should see like an intense increase in aging adults, 65 plus. So there's that piece. So knowing that the data will shift and grow for sure, and hopefully that whole data collection can be taken. I've provided some feedback to Vermont, the health department too, when we've met, saying that there's some data here that I'm not getting, and hopefully that conversation leads to a solution.
Thanks, Tony. So the reason I ask that is because much of the work that Hillary and I do focuses on the results of the Youth Risk Behavior Survey. Mm-hmm. And because we have in the Upper Valley, we have a handful of schools that obviously take the New Hampshire Youth Risk Behavior Survey, and then we have at least 2 schools in our region that actually take the Vermont YRBS, even though they are on New Hampshire soil. So each state has the opportunity, and I'm not sure if the group knows this, each state has the opportunity to include and sort of word questions the way they want to. They can't go crazy with it. Mm-hmm. But so that being said, Vermont and New Hampshire do not ask the exact same questions on the Youth Risk Behavior Survey. So that makes it challenging for us to make sure we're getting good data. But the Vermont side asks questions, and is able to break the data down and get us some of this information, specifically LGBTQIA plus information, whereas New Hampshire doesn't. So I was just curious if you had, and maybe, you know, I think maybe that's a side conversation that I could pick your brain a little bit more with that, but that's something we've always struggled with on the New Hampshire side, is we just don't have information for those students that, you know, that identify in the LGBTQIA plus community, because we know what we see in Vermont is that that those youth have, I don't know the exact, I can't remember the exact stats, but, you know, higher rates of, I think, past 30-day use of alcohol. I know the questions revolving.
There's like tobacco, marijuana. I was looking at the stats of that. I read through the youth risk behavior assessment, the most current one.
Yeah, so it's something we're pushing for on the New Hampshire side, but so I think that's maybe a side conversation for us. But that's the reason I was curious if it was, you know, data just for the Vermont side, or if you could, you know, help us with some insight on in the New Hampshire side. So
yeah,
I'll follow up with you and chat more about that.
For sure. Yeah, anytime you do, you know, we can definitely connect and talk about that issue, because I think that's definitely, for this unique area, I feel like that itself is a health disparity, is having the lack of consistency and lack of representation in the data collection. Vermont tends to be a little bit more inclusive when it comes to assessing surveys and the community representation. New Hampshire, outside the Upper Valley, has a little different perspective, and that can definitely limit the quality in the assessments, which I would continue to advocate for similarities or even the use or substitution of an assessment. I understand using Vermont assessment is it's different than New Hampshire, and you won't be able to compare as easily to other locations in New Hampshire. But I think to really get that representation data, like there's pros and cons to both, you know, and you're going to gain something, you're going to lose something. And you're, no matter what David decided, that's kind of a decision for yourself to decide. Do we shift schools to do just the Vermont one until New Hampshire can get on the same page? Or or do we just, you know, have the mix? And, you know, that in how useful is the data if you have the mix, and how can that be more representative to understand the disparities that students deal with? And in New Hampshire schools, you know, there are Vermont residents that go to New Hampshire schools. There are the town of Stratford. They have an opportunity to go to Hanover High School or Thetford Academy. So that data right there is, you know, they may experience certain issues. And if their social circles are on the New Hampshire side and they're coming back to Vermont, it's, you know, you're missing a piece of the story in the data because of that. There's a lot of interconnectedness. So I definitely can see that as a struggle.
Yes, I was just thinking, I mean, it sounds really interesting, the work you're doing, but it sounds incredibly challenging in the time period you have. Like, you have huge topics, huge issues for a complicated area, and you're going to narrow in on it and then do funding. And it's, I don't know, it just seems very tricky. And I know alongside that, at the same time, the community health improvement plan, I made that up. Is that what? Oh, good. Thank you.
You got it. Yeah.
Community health improvement plan is going on, and that's, I feel like that's tackling also, right, the issues and challenges in the community. So your stuff should be feeding that, or that some of that. I don't know. I guess
I feel like there's a relationship. Yeah. There's a relationship and a little interconnectedness there. Because, you know, this piece is primarily like hyper focused on the health disparities of marginalized communities in the area, and I feel like that creating integrating that into the plan is also making it more equitable. So it's adding value. You know, I see it as added value, to that process. Yeah, and I think in this work, you know, I meet with a lot of DEI coordinators, you know, in education or in healthcare, and we're kind of like a support for each other. And it's a great thing to have other people that are dealing with the same similar stresses of how do we deal with all this and how do we take care of ourselves, um, and and with such limited time. And it's kind of like creating realistic goals, and part of the process is creating a problem statement. And in that problem statement, it's kind of how there's so many things that we could do to an endless amount of work that we could do to help with the health disparities in the area. But what in this year do we want to focus on? Is it mental health and wellness and substance misuse, you know, that creates a little broader but still a narrow scope, so that the funding isn't so like, you know, only people who are doing XYZ can come and get funding. It broadens the people who can come get funding, so that those disparities can be met, you know, in that criteria, without, you know, and also barriers to funding, you know, consider barriers to funding. A lot of organizations are so small, there it's one or two people, and they may not have the ability or availability to do that. In the, you know, what we're hoping to, and this is an additional piece too, is what I hope that this is a capacity building piece, and this is a continuance of this work outside of the grant, is to create a learning collaborative, and inviting, you know, yourselves and other community members to a learning collaborative where we can all come together and we can share information, and, you know, we can complete the survey assessment that I was discussing. We can look at that and say, hey, where are we at? You know, kind of like, where are we at? And then 6 months from now, do it again. Where are we at? Like, is there an improvement? Do we see that the work that we've done has really laid the ground? And have that as a growing thing. I think looking at that as a capacity building within ourselves as a network, can really help beyond the funding of my work. Because, you know, I'm helping just get the funds distributed, but the learning collaborative is something that can continue, with one another, of how do we really take this as a base introduction, and how can we expand on that together, and tackle the issues that we're dealing with, and talk about the issues, like, you know, example, Andrea, the example with the data, you know, that kind of thing. That, like, the learning collaborative would be like, hey, we're coming together, and we're going to focus on data collection today, and let's talk about what our issues are with data collection, and how can we, you know, tackle health disparities based on the data and the quality data we're getting, and how can we collect data differently, or how can we work with the systems that we have in place, and things that we can control, cannot control. So Learning Collaborative is a great opportunity. I will be sending out some information about that in August, so that everybody can, you know, get through that, you know, try to take the assessment, see how it goes. And if you're interested in the Learning Collaborative, it would be kind of like this, you know, it would be kind of like a group setting where we can all kind of share what are our key issues.
I think it's great. The other thing, if I put on my funder hat, because we have a public foundation, so as a funder, we're always looking for opportunities to better understand how we can fund and give capacity for inclusion and diversity in the Upper Valley, right?
Mm-hmm.
So there's a lot of statewide work that the New Hampshire Funders Forum and the DEI Affinity Group who I'm on is doing, but in the Upper Valley, it's different. And so I think that you can help inform the Upper Valley Funders Forum.
Mm-hmm.
So maybe towards the end of your work, working with Alice, and then Jill Marshall, who convenes the Upper Valley Funders Forum, doing a report out to them, because that could be a way of your capacity building, getting more future funding towards the things that you've kind of done seed, because it's more seed money, right? So.
Yeah, no, exactly. And then when I'm connecting with other community members, and finding community organizations that want to really expand or develop their work beyond the amount of money that we're giving. You know, we only have $150,000 that we're distributing. Say we have 20 applicants, and then we have to kind of look at that, you know, how much money and how far can that money go for them. And if there's more funding opportunities for them, then that's a good opportunity. And if you're saying, hey, I have this much funding that I want to distribute to make more equitable funding, you have people interested. Like, then you'll be able to be like, hey, Tony, where's where are the interested parties that may be interested in this? Who have you helped build capacity with that could use this additional funding to really expand their work? And that's a good, it's connecting, it's making a lot of connections. So yeah, I think there's a big benefit to that.
Tony, I wanted to add, in terms of our, so the community health improvement process, but then even thinking, I'm guessing Alice shared with you the Upper Valley Community Health Needs Assessment. It'd be great to get your thoughts on the questions that we asked and thinking about data collection methods and how we could improve for next time.
Yeah.
So if Alice has shared that report, because I think while we formulated the questions, we were trying to think about questions around diversity, equity, inclusion, but it'd be great to get your feedback and ask the question slightly differently next time.
Yeah. I'm more than happy to take a look at it and give you some guidance on that. I think the learning collaborative too is like, those are the type of things that you could to be like, I'm working on this, and then make connections there of, oh, here's someone that can definitely help me too, but yeah, I'd be happy to, it's understanding, I'm making connections with the community. I'm understanding a lot of the needs. My background, I'm Guatemalan. English is my second language. I speak it very well. My Spanish, I feel is like more like Spanglish nowadays, but I don't get too many opportunities to speak Spanish besides my family. But I would say that, there are times where, I've taken my own like assessments at doctors' offices, or I've taken assessments at school and stuff. And there's definitely ways that even just the smallest ways is to just change a word or change a phrase. And in getting in the practice of that, it's practice. It takes practice. And I think once you start working that muscle, it will just like the weight off your shoulders will just and I'm happy to help you out with that. No problem.
Yeah, that'd be great.
Any other questions or
Yeah.
thoughts from folks? I'm sorry for exiting so abruptly. I did not mean to do that. But I'm back now. So I missed messages if you put them in the chat right before I left, but I think I caught up on everything. So any other questions or thoughts for Tony? Okay.
I'll make sure I leave my email in the chat. So if anybody wants to reach out to me, feel free to. If you have any follow-up questions, or then tomorrow you're like, oh my gosh, I should ask this. feel free to email me. Okay.
Good idea. Will do. And you're welcome to, come back to our coalition meetings anytime, and would love to keep working with you.
Oh yeah, no problem.
Yeah.
I did have a question, or something I was thinking about around 988 and equity issues, because I was seeing that, right, 988 is supposed to replace a 911 call for crisis interventions, but that for certain populations, if the risk is determined to be too great, they might still, on the call, use geolocation to find someone's where they are and send police to go, to intervene. And for people who are trans and people of color, that having police suddenly show up for you at this moment can end up being harmful. And so kind of wanted to before you left, Tony.
Yeah.
Raise that as an issue because I saw that was next on the agenda. I don't have any specific question. It was just something I was reading about and wondering how the New Hampshire crisis line deals with that and whether anyone knew any information.
I will add one thing about that response. My position before I moved back to this region, I worked for Denver City Council, dealing with these exact issues were something that we were discussing in the safety committee, and in council are the police the first response? Should they be the first response? And is that a safe first response to have? And they have a program that's funded through the mental health care provider in the region. It's called the STAR program. They're social workers and therapists that are, they either accompany police officers or they show up first, depending on the level of concern and safety. And I see that the data that came from that, just seeing the data that came from that was really a big improvement. And also having, on the suicide prevention lines there, having trauma informed and culturally responsive and competent dispatchers was extremely helpful. And sharing those crisis lines for organizations that are a little bit more trained, like the Trevor Project or other resources that are out there. I have a list of some that are rather inclusive, but I think 988 is a great opportunity and a great thing for mental health care. But there's also, looking at the equity piece is I know for myself, if a police officer showed up at my house, if there was an emergency within my family, say my father has had a mental episode or something and needed extra support, and where we are 100 miles from the border. Always keep that in mind. We are 100 miles from the border. So within 100 miles of the border, ICE has jurisdiction. So consider those who are undocumented, who are people of color, who have dealt with immigration, what that may feel like, especially when you're having a mental health crisis. So it's always trying to put yourself in the experiences and shoes of other people that you may not identify as. And I find a big improvement with Denver when they started funding the STAR program so much, and how that's kind of come about over the past 10 years of data and seeing the amount of calls that they've responded to and how helpful that was for the community members.
Tony, can I chime in a little bit?
Sure.
So hi guys, I'm new. My name is Miranda. I'm jumping on board from, I actually was on Sullivan County's team. I am the new Lebanon School District social worker. But I worked at the Clara Martin Center in Vermont as an emergency clinician for 4 years. Mm-hmm. And so Vermont, it would be also beneficial if you feel like 988 might not bring the right support, that a lot of the local mental health agencies still have that emergency contact number that will get you to a trained person as well who is local and might not come with the police officer. There are times where they still have to, make that judgment call, but we do have some really great local resources that don't necessarily involve law enforcement first. So something to know about.
Do you know if there's a connection between, say, the Clara Martin Center and other providers in other regions? Because I think that would be a big missing piece.
In the state of Vermont, every mental health agency has to have that emergency number.
Okay.
So all do have that. It just depends on which organization what catchment area you're in. So like Windsor is HCRS, Burlington, I totally forget the name, but each area has differently. But New Hampshire also has started kind of funding that through West Central. They have an emergency number that you could call directly. So I know New Hampshire just started with their new dispatch and the way that they're doing it now, but they also can provide someone on scene if you were, like you said, if you were at your house and your dad was experiencing a crisis, you could pick up the phone and call that number and get a person instead of the police.
Okay.
So
that's interesting.
they do, sometimes if there is imminent concern and the person going there is in danger, they will often come with a police officer, but it will be that mental health person first, and the police officer is just kind of there for safety concerns. But that's usually only in kind of bigger situations where they need that. I did many calls to people's homes just to meet with someone.
Okay. No, that's interesting. I hope there's a integration of those resources with the 988.
Yeah, I haven't looked into how they're overlapping or if they're working together. So I don't know how that goes. But
yeah, I could see that as being helpful, so that it's not, the response is done timely, but also having the right people in the right spots instead of, doing more harm than good.
Miranda, thank you for bringing that up and for introducing yourself. I wanted to make sure that you did that, but it's good timing and good segue because our next presenter is actually going to talk about the 988 transition in New Hampshire and, a little bit about how these different numbers overlap and work together. So perfect segue. Thank you for queuing us up.
I do have to actually check out though, because I have another meeting.
So fine. Thanks for joining us. All right. So I see that Jenny O'Higgins has joined us. Are you there? Can you hear us?
I can hear you. I have actually somehow in this whole time of COVID, I have never used WebEx. So
okay.
I don't know how that's.
Do you have video or
The video says another application is using your camera. So I was trying to figure that out. And I'm also trying to figure out how to share screen. So I have
maybe you have Zoom. Do you have Zoom application open perhaps, or Teams, or there's another one of you coming in. Okay.
Yeah, I don't know. There just might be several of me.
Okay. We're gonna mute one of us.
There you go.
Let's see. Okay, we see you.
Okay, I left
hear you.
The other person. Can you hear me?
Perfect. Yes. Yes.
Okay.
So you're right on time, and we were just having a discussion at the end there about the new 988 stuff going on in New Hampshire. So I will let you introduce yourself and jump right in if you'd like. And if you need to share your screen, I think you can. If you need host privileges, we can make sure that you can do that.
I just made her a presenter, so she should be able to share.
Perfect. Thank you, Hillary.
Yep.
All right, great. Thanks. So I'm actually off today. So I happen to have just come right in from a family occasion to make sure to be with you all today, but I will just ask for a little bit of grace in my presentation, both with my weird audio and video from right from the get-go, but also in that I'm just sort of swooping in to spend this 30 minutes with you. And I am not in that sort of, all day work mode right now. So I'll just start there so that everybody will give me a little grace. And I'll introduce myself. I'm Jenny O'Higgins. I'm a senior policy analyst with the Division for Behavioral Health. So I'm at the Department of Health and Human Services. I have been there for 2 years already, but that whole time has mostly been in virtual world. So I have not gotten a chance to get to meet all of our community partners as much as I would have liked to. I came from working for the IDN in the Greater Manchester region, so I do have some experience working across behavioral health integration, and my previous roles before that were all in youth services. So just to give you a sense of sort of where I come from, and my passion is really, prevention and early intervention in particular. And I'm going to talk to you a little bit about sort of rapid response in the state and all of the different crisis transformation you've probably been hearing a lot about. I don't have an awesome sense of who all is here, so feel free to just jump in and ask me questions or say we already know all of that and move on. And that would really help me out. And then after I got through some, basics of what we're doing with rapid response and why we're doing that in New Hampshire, I'll talk about 988, and then we'll talk very specifically about the similarities and differences or how those systems work together. And then you'll have lots of questions, I bet. So I think it's still somewhat complex. And we're in a place where we're getting, moving towards a better system. But when you say, crisis system transformation, it just doesn't happen overnight. So we're kind of in the beginning phases of something that's going to be much longer term. Okay, so I've clicked on share and we'll see if it will let me do it. Am I back from freezing?
Yep, we can see you, we can hear you still.
Great. Okay. All right, so let's see if this gives you the rapid response presentation. Are you seeing the are you seeing full screen or like presenter notes?
Presenter note mode.
Yeah, let me just try to get rid of that just because it's so hard to read when it's that small. How are we doing now?
Now we do not see your screen.
Oh, fun. I mean, I really have been presenting online for 2 years now. It's like so weird that I have not had a WebEx experience, but every day is a new challenge.
That it is. Now we're good. We can see it. Yep.
Okay, great. So we're going to talk through this New Hampshire's approach to crisis system transformation. I'm going to go somewhat quickly, and then I would rather spend a lot of time making sure that I'm answering your questions. So really, there's multiple pronged reasons why we got here in New Hampshire. You all are probably familiar with New Hampshire's 10-year mental health plan. So that was a large process of collecting stakeholder input, input from community members, people with lived experience, family members, to make sure that we identified as a state where we were falling behind and where we had success, and set forward recommendations for our mental health system. And so that plan calls for a regional delivery of mental health services across the lifespan. The 10-year mental health plan also called for a centralized portal with a single source phone access point. So for call, text, and chat. And it also asked that both of those systems serve both children and youth, which previously our mental health care system in some ways had been focused on adults. And it also had been focused on mental health in particular, with a separate, distinct, and siloed system serving those with substance use disorder. And so there's some calls for integration in the 10-year mental health plan as well. The system of care was a piece of legislation, SB 14, that required mobile crisis services for children and youth. So at the time when all of these things came about, we had 3 urban regions in the state, in Concord, Manchester, and Nashua, who had stood up some availability of mobile crisis response teams, but it was not statewide. It was not serving children, and it was not serving substance use disorder care integrated with mental health. So those are some changes that we have been looking for in the rapid response system. And the other pieces you'll see in here are just around national best practice from the Crisis Now model, and best practices in behavioral health crisis care, and the Governor's Commission on Alcohol and Other Drugs, and the Bureau of Drug and Alcohol Services moving their model as well to have mobile crisis and a centralized access point. So all of those things sort of coming together are the drivers for how we started to change this model. So the easiest way to sort of describe the services, I think, or from the Crisis Now model, is that there are three main pillars to that model, and they're someone to call, someone to respond, and somewhere to go. And in New Hampshire, these initial steps that we are taking to transform our crisis system include really the first two of those three pillars. So the someone to call is really the creation of this 24/7 centralized access point that is operated by Beacon Health Options. You can call, text, or online chat that 24/7. They can do, you can really call, text, and chat with any type of emotional distress, inclusive of suicidality, inclusive of substance use, inclusive of mental health crises. You do not need to have a diagnosis. Anyone can call, and they're able to do some of that phone triage and de-escalation. The access point is also able to, when needed, deploy local face-to-face services. So the second pillar is that someone to respond. And that's when a caller is, unable to be de-escalated and needs a bit of a higher level of assistance and is looking for that in-person response. That the access point works with our 10 regional community mental health centers to deploy rapid response mobile crisis teams into the location. And the teams are staffed with a clinician and a peer. For the most part, that's the model. Of course, we have some workforce challenges in the state, and we have had some ability to say bachelor's level and a master's level can deploy together, two peers can deploy in certain situations. Master's level alone can do telehealth work or in a secured facility if they were responding, for instance, to jails or prisons, as an example. So there's a little bit of flexibility in the staffing model, but for the most part, it is a clinician and a peer pair. So I'll stop there for a minute because that was already quite a bit of information. Does anyone have questions about these two sort of pillars that we are working on, standing up today in the state? I also should mention that I can't see any of you when I'm sharing screen. So please just audibly yell at me if you have any questions. Are you there?
It would be great to get this presentation if you can share it when you're done with Andrea or Hillary or
Sure. Yeah. And is this too basic? Is this helpful as I move forward?
This is Elena, Jenny.
Yes.
I think it was very helpful. It's appreciated. I am wondering if this crisis response is the same format that West Central has been communicating, at least in the Upper Valley, or if it's a different process.
Nope. So it is still that all 10 community mental health centers, per their state contract scope, that they are all required to stand up the mobile crisis response teams. I will say that we're in the beginning stages of doing this model. This has only been a couple of months. And so I can't speak specifically to where West Central is at with their hiring and how that's going. Other members of my team are much more integrated into what each of the regional CMHCs are doing and how that's coming along. I'm happy to take back questions or feedback more specific to your region, of course. But the vision statewide is to have these mobile crisis response teams that are available and operating 24/7. And so if we're not there yet, it is where we're going.
Thank you.
Sure.
And I would like a copy of your presentation too, as I can help bring it back into schools that I'm in, as well as ensure that Miranda has a copy, which if it's in the minutes, she'll have access to. So that's great.
Great. Thank you. I will keep going, but I wanted to kind of pause and make sure I was making sense. I think it's fairly dense information to get through. So I'm going to, take our time to make sure we're all processing it. Okay. So I'm going back to sharing. I have to stop sharing every now and then because I can't see you. So that seems challenging to know whether or not you're asking me anything. All right. try this again. Okay, so the purpose of our system, this really gives you some of a lot of the basic tenets of what the system's looking to do. So I've already talked through the fact that we want it to be integrated mental health and substance use care, that we want it to be available across the lifespan, so inclusive of children. Really, the model is changing to be much more person-centered. So previously, our system had been driven a lot more by clinician and clinical diagnosis than by when you can call, based on what a self-defined crisis essentially, and empowerment for people. And so it's much more inclusive of peers and much more informed by people with lived experience than I believe our previous system had been.
Jenny, could you I don't know that the slideshow has started. We just see the small version.
Oh. So see, I stopped share and then it's like I gotta do it all over again.
Sorry.
No, not your fault.
I don't know why it's not changing to like show the slides. I don't know.
No, it's too bad that it can't make, and nothing can be easy these days. Just sort of where we're at. So when it asks me to share this,
you can select like a screen, or you can select that specific application that you want to share. So you can select just your PowerPoint application.
Yeah, it just says screen and it shows it little. And I don't know how I made it big last time.
Did you hit start? You hit start from current slide and it didn't do anything?
Yeah, so it's still small for you. It looks larger on my side. I'm gonna try to try plugging in a second screen, so maybe
It's not terrible. I mean, I can read it if I sit forward.
If you just if you drag down the bar between the slide and where it says click to add notes, but I don't know if that's what you were seeing or not. But if you drag that down, it will make the slide bigger.
Do you have multiple screens, Jenny?
I'm just plugging one in. I don't have up a second screen, but I have one next to me.
Sometimes, yeah, sometimes when you have two screens, it picks the wrong one, but we can read it if you want to just use it in this format, in the little, it's bigger now. I mean, it's in the smaller format, but we can read it if you wanted to just use it here. That's fine with us, I think.
Yeah, it looks better now.
We're all so flexible and resilient these days. Okay. I'm going to unplug the second screen because it's not showing up anyway. I just felt like I had done it correctly at some juncture, so I'm trying to make sure. Just trying one quick other thing to see if I can just figure out what I'm doing wrong, but nope, it's really not letting me. I don't know why.
I don't know if it's easy for you to send it to us by email. We can share it for you, or.
All right, is it still showing that small version?
Yeah, but that's okay. We can see it.
Okay, well, anyway, I think we could actually talk through all of this without the slides. I mean, it is all either way. So I will show just these small ones for you to get a sense of it, and then I'll send you the presentation.
Great.
So the rapid response model in New Hampshire launched on January 1st. And so that was the Beacon Health option, standing up this single statewide number. There were over 20 emergency services, mental health crisis numbers in the state of New Hampshire that we were advertising, including emergency services at all 10 of the CMHCs. Those call lines didn't sunset in case, existing clients have those phone numbers and we're used to calling emergency services, but they were routed into this single statewide number. So that way we're able to utilize this 24/7 call center, and that they're able to then deploy those rapid response teams. They're also able to book location-based services, so follow-up appointments at the CMHC. They have specific times that are held And then there is follow-up for every single call, text, and chat. If a mobile crisis team is deployed, it will be the mental health center that's doing the follow-up. And if the call center is able to de-escalate the call by phone, text, or chat, it will be Beacon Health Options, the access point that does the follow-up. I'm just looking at this thinking, is there anything I haven't said? I feel like I've told you essentially the steps of how it works and the follow-up services. So now we'll talk a little bit about 988 in New Hampshire. So it's interesting. I've been talking about 988 for a year and a half or so now. And all of a sudden I keep saying July 16th, 2022. And now all of a sudden that's passed. So last weekend was launch weekend for this national resource. Essentially what 988 is that the National Suicide Prevention Lifeline, which has been in existence for 50 years, is transitioning to this 3-digit number. Now, on a grand scheme, in the same way that I talked about New Hampshire having a vision for a system and that vision not being fully realized because that's being in the earlier stages of implementation, that there's a similar thing happening with 988. So 988 on a national level has been a rallying cry for a mental health system transformation. It has been brought about unprecedented policy change and billions of dollars in funding, essentially, just in a very short period of time, right? So it's the biggest thing to happen to suicide prevention in decades. However, right now, 988 really is still the access point itself. It's still the National Suicide Prevention Lifeline call center. So while the vision is in line with the vision I just explained for Crisis Now and for the New Hampshire's rapid response, where you would have someone to call, someone to respond, and somewhere to go. And those are listed in these 3 bullets of a call center, mobile outreach, and crisis stabilization. 988 isn't there yet either, right? So it's sort of the national version of rapid response. So when that 988 number went live in July, the rapid response system had just started in January. Headrest up in Lebanon had been taking National Suicide Prevention Lifeline calls for 35 years. And so they have been they've been the only New Hampshire-based Lifeline network call center in the state of New Hampshire for years. And so bringing on Beacon Health Options as an additional call center and getting them accredited with the National Lifeline allows for us to have 2 New Hampshire-based call centers answering those 988 calls and those National Suicide Prevention Lifeline calls. Even if people still use that 10-digit number, it will never sunset. And so that allows for a better in-state answer rate, essentially. So when people call from a 603 area code, they're routed by area code to their local center. And so, but the Lifeline has some really specific metrics where they don't let the phone just ring and ring and ring. So if a call center isn't able to pick up very quickly, they will bounce it to the backup call center in that state. And if they don't pick up, they will bounce it to the national network so that Lifeline calls always get answered within a minute's time, essentially. And so they try to make sure that those calls are answered really quickly by a live person. And so we had about a 78% in-state answer rate with Headrest alone. But that means, that callers from New Hampshire were still getting national backup. So the additional infrastructure and capacity of having 2 call centers allows us to have higher in-state answer rates. Any questions here around all of that and 988?
Yeah, I have a question for you, Jenny. This is Margaret Dry. My kids all have 603 numbers, but they live all over the United States. So if they called, would that route them to New Hampshire?
Yes. And so that's part of, and I have another slide sort of describing exactly our messaging and when to call 988 versus rapid response. So essentially I have a Massachusetts cell phone. My husband has an Arizona cell phone. So if we call I'm going to get a Massachusetts center, my husband's going to get an Arizona center. So how we understand crisis numbers to work in these 3-digit numbers like 911 is they have geolocation services available. So they ping cell towers and 911 knows where you're located. 988, the FCC on the federal level did not approve geolocation for 988. Part of that was based on advocacy from people with lived experience who wanted to remain anonymous. And part of the conversation is still going. And a lot of mental health advocates are saying, hey, when we have these enhanced crisis systems that include the ability to have mobile crisis teams or local follow-up resources, people aren't getting access to everything that they potentially could have access to within their own community. And so there's a lot of ongoing conversation about whether or not geolocation may be approved in the future. At this point, because it's not, we have to be really clear with our messaging that 988 is a national resource. And for a New Hampshire-based response every time, you're going to call 833-710-6477. So that's the rapid response number directly. That's really the only way to guarantee you that you're getting that New Hampshire center. 988, it is not, it sounds like it's all very confusing, but we have always advertised the National Suicide Prevention Lifeline as a potential resource, and it has always been a national network of call centers. So we've never sort of advertised that and said you'd get New Hampshire. So all the nuance of routing, it is complex, and I'm happy to talk through it. But I also think that for our community members, and especially folks in crisis, it's hard to get in the weeds on all the routing. And it's easier to be able to say, yes, 988 is a great resource. It's a national resource. If you're looking for New Hampshire-based services, you're going to call rapid response. And in a year, those two phone numbers may be the same thing because geolocation may be approved and you might get a New Hampshire center 100% of the time. But today, that's not true.
So if you call 988, can you ask, can you say, I'm calling, even though I have 773 area code, I'm in New Hampshire, can you?
No. So there is no transfer of calls from the Lifeline. So the Lifeline protocol is that you would never transfer a person in distress. And the reason is that there's many dropped calls with transfers and you don't want to hang up on a person in distress. And so the protocol is only that de-escalated callers can be transferred or given resources in their own state. So if my call's answered in Arizona, I'm sticking with Arizona. And
that means that there would be no, I wouldn't be able to ask to have someone like the mobile crisis unit deployed to come see me.
Nope. So you have no access to the enhanced New Hampshire services by calling 988. There's probably 80% of our callers who call 988 are going to get a New Hampshire center, and then they're going to have all the services that rapid response has. But if you want to be clear without the nuance of the routing, it really is that you still call the 10-digit number advertised for rapid response every time. Until there's geolocation services available, 988 is a national resource. It is not a New Hampshire-based resource, and you will not reach New Hampshire every time.
So by calling the New Hampshire rapid response number, it uses geolocation.
Nope. They use geolocation not for the individual, for the rapid response teams.
Okay, so no one would assess me that I was in need of a crisis intervention and come see me without my consent because they wouldn't know where I was.
You provide your location. So there's always been, for every crisis call center that I'm aware of, there's a difference between like warm lines and befriending lines and things like that. But for the National Suicide Prevention Lifeline and crisis lines that I've been aware of in other places, there's always a chance that if someone is suicidal or homicidal with intent and means, and the crisis is life-threatening emergency, that person's number will be given to 911 who has geolocation. So there's potential that geolocation services would be done by the first responders to find an individual to reduce that loss of life potential. That less than 2% of Lifeline calls are ever in need of what they call active rescue, but I feel like we need a new term. I don't know why, but I don't like it. But so that has been a very low number of calls, but that has been the case. But when we talk about rapid response having any geolocation services, I actually want us to stop saying that word because it's getting really blurred in the national debate around these barriers for 988. New Hampshire, we have cool technology and it is geolocation, so it's not the wrong word, but it's not for the individual in crisis. It's so that when the individual in crisis tells us, I want a rapid response team to come to my house and I'm sitting in, 173 Pearl Street in Manchester, New Hampshire, this is where I want you to come see my family member or myself. The open beds technology used by Beacon Health Options at the rapid response, they can see where their rapid response teams are located and they can deploy the closest team to hopefully be at the person's location within 50 minutes. Thank you so much for asking that, because I feel like it really needs to be clarified. And with 988's launch, there was a ton of exciting media around the potential benefits of 988, and there was counter media saying don't call 988, it's not friendly, police are going to come to your home. And I don't want New Hampshire, if we can help it, to get caught up in some of that based on us saying we have geolocation when the geolocation is not for the person. And I think we've said we have geolocation because we were excited by technology, right? So we've been talking about it because we're like, isn't this cool? We can see where our teams are. But we have permission to see where our teams are. That's, that's different. So it's not some of the privacy consent issues that are being discussed about the FCC approval for geolocation on the national level.
Okay, that's helpful.
Jenny, I just had a quick question, sort of go off of what you're just talking about, and the people calling in sort of with a family member in crisis. Could you talk a little bit about the difference in response potentially between someone who is calling on behalf of a family member who is above the age of 18 versus under the age of 18? Because I know it differs slightly.
Well, so a lot of times family members calling are also in crisis themselves. So they're experiencing a crisis. And so we may deploy a mobile team, and the individual identified as the person in crisis the call was about doesn't want to meet with the mobile team. We're still going to go out and talk to mom, even if that person's an adult, right? And so it's based on the urgent need of the crisis that's happening. And so the access point's going to do an assessment to look at dispatch criteria, right? And it's going to fall into color-coded dispatches. So green means that everything's pretty safe on the ground as far as we can tell, and yellow means that we might be escalated and we need to de-escalate them. And then orange is saying we're going to deploy a mobile crisis team, and then red is saying we're going to co-deploy with emergency first responders, or we're sending them alone. Right? And so that's going to be, they're going to assess the scene through a series of questions. And then we have a close partnership with 911 as well for life-threatening emergencies, and also for 911 to transfer to us when they're receiving behavioral health calls that could actually benefit from a rapid response team instead of a law enforcement approach.
Thank you. That clarifies things.
And all of this is like, I am coming to you talking about it as like the visionary, this is what we hope for. I am not pretending that this is exactly what's happening on the ground every day in the state of New Hampshire. We are standing this up within a couple of months. We are having plenty of growing pains, and we are very open to feedback. And we don't think we can build a system to get to the place where we want it to be without that feedback. So we're all about that, full on community partnership and really building the system with people who are utilizing the system so that we truly know whether or not we're doing more harm and how do we get to the place we need to get to, And so a lot of the Crisis Now model is talking about diversion from emergency departments and incarceration, right? On the national level, we know that these are challenges. And I think we have a much better system than we had a year ago. And I'm fine and comfortable with saying that doesn't mean it's good enough. And it doesn't mean it's fully equitable. And it doesn't mean we have full language services. And, we're getting there.
I think we'd love, as an all-together staff, would love to meet with you, Jenny, offline to talk about how we can perhaps change some of our language on our crisis resource page on our website.
Okay.
So we'll have Lauren get in touch with you to see if we can schedule an offline meeting to talk further about ways that we can help with messaging.
Okay.
can I join the conversation too, thinking about how APD can make sure that we're including the right information on our website? And then I also sometimes still share information from Upper Valley Strong too. So useful to, like, I shared this slide that I'd seen from the state encouraging people to call the New Hampshire Rapid Response number versus calling 988, especially for people with a non-New Hampshire number.
Is it this one?
Yeah.
Great.
And then just, you know, because we happen to be a bi-state community, what happens if someone's on the Vermont side?
So Vermont has their, you know, their own services essentially. And so we're actually having some, so you would, if they may, the Lifeline requirement, it is a national network. So if you call 988 from your Vermont number, but you end up at a New Hampshire center or whatever, they're going to de-escalate the caller no matter what. Like you said, they don't transfer calls. They sit with the person and they work to de-escalate the issue. We are having calls with our regional Lifeline centers, all of our regions and their state DHHS partners. We requested that from SAMHSA and federal HHS because as the nation starts to try to figure out crisis transformation, we know it's going to take longer. And so because they say, like, we won't transfer calls to other states when you need it, our thought is that if we could list our region as each other's backup centers, instead of us having 2 Lifeline call centers in the state of New Hampshire, maybe we also list Vermont, Maine, and Massachusetts and all their call centers. And then that way we only stay within New England no matter what. And then we could get them the technology to help with our follow-up appointments and our crisis teams. And we would do the same for them as their backup network. So then we start to strengthen sort of everybody in New England is able to get the enhanced services. And then we, you know, you slow build it. It's easier to build a system in a town than it is in a city, than it is in a state, than it is in a nation. So we are looking at a potential regional approach, but we're not there yet. I don't know if that fully answered what happens in Vermont because I don't fully know what happens in Vermont yet.
I think I already knew what would happen, right? Like, it's the West Central's not going to deploy the mobile crisis unit across into Vermont.
Yep.
So actually, my question was a bad question, and you answered the question that I should have asked. So yeah, it's nice to hear that there's thoughts about how our region can work together.
Yeah. So, I mean, at the call center level, too, it doesn't matter where the caller called from. If they make it to, like, even whoever, I'm sorry that I couldn't see you when you asked, but someone asked about their college kids with 603 in other states. If they call and they get to a New Hampshire center, they're going to sit with that New Hampshire center, and that New Hampshire center is going to work with them to get whatever resources they need. If that means Googling what they have in you know, Georgia, because that's where they are, they're going to, right? And our call center headrest up in Lebanon has taken calls from Hawaii and Japan, and right, because people are abroad and they're calling into the National Suicide Prevention Lifeline, and they will do the very best that they can for the person on the phone, and that will remain true. I think when we get into a lot of the nuance, we're talking about callers who need additional support in person. So we're talking about the ability to deploy mobile crisis response teams, you know? So it's still going to be this incredible resource of 988 for, you know, I mean, the new modalities of text and chat are going to be excellent for young people. There's potential connection for deaf and hard of hearing community that would not have as much equitable access through phone alone. Right. So, I mean, I think just the addition of the modalities and the addition of the expanded serviceable population and the idea that you call in any emotional distress, the whole tagline is really like call early, call often. So we're not waiting for people to be specifically in suicidal crisis, right? We want to get upstream wherever we can. And I think all of that is really positive. I think we're all kind of really caught up in the nuance of the complexities of the phone routing. And we have to be because we're the providers and we need to make sure we get it right. But I will just try to also throw out some of those positives.
Thank you, Jenny. I want to respect everybody's time. We've gone over a little bit. So I think if there are additional questions that anyone has for you, could we provide our email, your email, and either they can email us and we can pass them along to you, or could they email you directly if they think of other questions?
Yeah, of course.
Okay.
I'm a public servant. Always available.
All right. Okay. I guess thank you all. That was our July meeting, and it was packed with lots of information. So we'll be sending out the minutes and the notes and any other relevant information from today's two presenters.
Awesome.
Thank you all.
Thanks, everybody.
Thank
Bye.
you.
Bye for now.